Welcome to our training on suicide prevention using the Zero Suicide Model. In addition to watching this video, the majority of this lesson involves reviewing the numerous documents that are attached in the lesson media section of this lesson. The attachments include 2 assessment instruments, several handouts included in the Zero Suicide Model, a guide from the Joint Commission regarding safety goals on suicide, and a PowerPoint slideshow from Zero Suicide. For your convenience, a copy of the PowerPoint slides for this lesson is included in the lesson media section of the lesson. When you have completed all of the material for this lesson, you are required to complete the attached quiz with a passing score of at least 70% to successfully complete this lesson. People who die by suicide have touch with the healthcare system. 83% of those who die by suicide have seen a healthcare provider in the year before their death. However, only 29% of those who died in the past year were seen in outpatient behavioral health. Across health and behavioral health care settings, there are many opportunities to identify and provide care to those at risk for suicide. Before that can happen, suicide prevention must first be seen as a core responsibility of healthcare. The Zero Suicide Initiative is defined by a system-wide organizational commitment to safer suicide care in health and behavioral health care systems. It is a culture shift away from fragmented suicide care toward a holistic and comprehensive approach to patient safety and quality improvement, the most fundamental responsibility of healthcare, and to the safety and support of the staff who do the demanding work of treatment and caring for suicidal persons. Zero Suicide fills the gaps that individuals at risk for suicide often fall through by using evidence-based tools, systematic practices, training, and embedded workflows. Continuous process improvement drives the framework to ensure that organizations deliver quality of care, routinely examine outcomes, and remain committed to the fidelity of the Zero Suicide approach. This approach builds on successes supported by data in healthcare organization. With a focus on suicide care using such rigorous quality improvement processes, Henry Ford Health System demonstrated stunning results. A 75% reduction in the suicide rate among their health plan members. Centerstone, one of the nation's largest not-for-profit community mental health centers, saw a 63% reduction in suicide deaths after implementing Zero Suicide for 3 years. There are 7 elements to the Zero Suicide system of care. These elements are: number 1, lead a system-wide culture change committed to reducing suicides. Number 2, train a competent, confident, and caring workforce. Number 3, identify individuals with suicide risk by a comprehensive screening and assessment. 4th, engage all individuals at risk of suicide using a suicide care management plan. Number 5, treat suicidal thought and behaviors using evidence-based treatments. Number 6, transition individuals through care with warm handoffs and supportive contacts. And finally, 7, improve policies and procedures through continuous quality improvement. While we would like to have the time to discuss the entire framework, we will limit our discussion to identifying, engaging, treating, and transitioning. The first challenge in preventing suicide is developing a consistent process for identifying individuals who are at risk of committing suicide. An estimated 9.3 million adults, or 3.9% of the total U.S. population, reported having suicidal thoughts in the past year. Approximately 2.7 million people, or 1.1% of the U.S. population, reported making a plan about how they would attempt the suicide. An estimated 4.6% of the overall U.S. population reported a lifetime suicide attempt. Yet, in a 2016 Joint Commission alert, failure to assess suicide risk was the most common root cause of suicides. Screening for suicide risk should be included in all mental health and substance use healthcare visits. The known risk factors that should trigger the screening for suicide include mental health or substance use diagnoses, psychological or psychosocial trauma or conflict, recent loss, a family history of suicide, and a personal history of suicide attempts. Evidence-based screening tools should be used in these assessments, coupled with clinical judgment, as this combination has been found to be more accurate than clinical judgment alone. Use of an assessment such as the Columbia Suicide Severity Rating Scale can help reduce the burden on the provider, encourage and streamline follow-up, and improve documentation of risk. The tool can be useful in increasing the quality of information gathered from the person served, encouraging self-disclosure, while also improving care delivery, treatment planning, and outcomes. Systematic use of this scale has been shown to increase the detection of suicidal risk and decrease the rate of suicide. While the Columbia Scale is widely recognized as an effective tool, no single assessment instrument will improve our detection of suicide risk. Instead, the commitment of the organization to the process of identifying risk is the critical element. Suicide risk detection must become a core component of the organizational culture and a value of each individual employee. For your convenience and review, a copy of the Columbia Suicide Severity Rating Scale is included in the lesson media section of this lesson. This scale is a measure that is used to identify and assess individuals at risk for suicide. Questions are phrased for use in an informal interview format, but can be completed as a self-report measure if necessary. It measures 4 constructs: the severity of the ideation, the intensity of the ideation, behavior, and lethality. There are 4 versions of the scale that are available. The first is the lifetime recent version, which allows providers to gather a lifetime history of suicidal ideation and behavior. The second is the since last visit version for assessment of suicidal thoughts and behaviors since the instrument was last administered. The third is the screener version, a shortened version of the full form which can be used in triage or intake settings. And the final version is the risk assessment, which provides a checklist of protective and risk factors for suicidality. All 4 versions of the scale are available at the Columbia University Medical Center's Center for Suicide Risk. The website is http://www.cssrs.columbia.edu. Interpretation of the instrument can take place on an itemized level, a categorical scale, or overall severity of suicidal ideation and behavior. Providers should use the instrument as a measure of suicidation, intent, plan, and past suicidal behavior. It can be used to guide appropriate services and to facilitate safety monitoring and planning. A critical element of suicide prevention is our level of engagement with individuals who are identified as being at risk. In the zero suicide model, every patient who is identified as being at risk for suicide is closely followed through a suicide care management plan. It is essential to continuously assess risk, engage the individuals in their collaborative safety plan, their service plan, and suicide care management plan, and re-engage the person at every encounter, no matter what the reason for the visit. Evidence shows that outpatient management of suicidal individuals can be safe, clinically appropriate, and at times preferable to inpatient care. But individuals at high risk of suicide are often among the highest percentage of those dropping out of treatment. Improvements in treatment compliance can be obtained through intensive follow-up, case management, contacts, and visits. Several studies have shown that engaging individuals by beginning interventions and treatment at or as soon as possible after emergency room or inpatient discharge has demonstrated significant reductions in repeat suicide attempts. The risk of a suicide attempt or death is highest within the first month after discharge from inpatient or emergency department care. 47% of those who died by suicide following discharge died before their first follow-up appointment, and 43% of suicide occurred within a month after discharge. Up to 70% of individuals who leave the emergency department after a suicide attempt never attend their first behavioral health appointment. So our engagement with individuals leaving emergency departments or inpatient care cannot be simply offering them an appointment within 7 days. To increase suicide prevention, we must take active steps to engage individuals who are transitioning between levels of care, such as face-to-face handoffs, follow-up telephone contacts, care notes, which are warm and inviting letters or emails that are sent to the person, and even home visits. Safety planning is an essential intervention with individuals at risk for suicide. It can be used with individuals who have made a suicide attempt, experienced suicidal ideation, or those who are determined to be at risk for suicide. Safety planning is not to be confused with contracts for safety or no suicide contracts. There is no evidence that these contracts are effective. Safety planning has been found to be more effective than a contract for safety. Safety planning is a brief intervention involving a list of coping strategies and supports developed collaboratively between the individual and the service provider. The safety plan is an intervention to provide individuals with a set of specific, concrete strategies tailored to their individual needs and circumstances that they can use to decrease the risk of suicidal behavior and increase treatment motivation and compliance. Research shows that individuals with higher quality safety plans are less likely to be hospitalized in the year after safety planning. A higher quality safety plan should include the following elements. First, warning signs, which is a recognition of the signs for that individual that immediately precede a suicidal crisis. Next are internal coping strategies, which are things that the individual can do to distract themselves without contacting anyone. Next is social situations that can help distract the person, which includes places the individual can easily access that provide a safe environment, like a library, a mall, or a coffee shop. Next is people the person can ask for help. The person should list at least 3 support persons who are available, able to provide support, aware of resources, and informed that they are part of the safety plan. Next would be professional or agencies the person can contact during a crisis, which are professionals and crisis support agencies, including the hours and contact information for the current treatment provider, local and regional crisis support services, and national crisis support that provides 24/7 crisis services. Finally, the plan should include making the environment safe, which are steps to remove access to lethal means, strategies to limit or eliminate substance use, and any other strategies to maintain a safe environment. One of the most widely used safety plans is the Brown-Stanley Safety Plan. For your convenience, a copy of this plan is attached in the lesson media section of this lesson. A key component of the zero suicide model is reducing access to methods that could be used for suicidal acts, and if possible, restricting access during an acute suicidal crisis. Reducing access to lethal means, particularly those with greater lethality, is essential in safety planning. Studies around the world have demonstrated that the overall rate of suicide drops when access to commonly used, highly lethal suicide methods is reduced. Every safety plan should address reducing access to any lethal means that are available to the person. Limiting access to medications and chemicals, and removing or securing firearms, other weapons, and ligatures are important actions to keep people safe. This is particularly important in light of findings about the impulsivity of many suicide attempts. Among people who made near-lethal suicide attempts, 24% reported taking less than 5 minutes between the decision to kill themselves and the actual attempt. 70% took less than an hour. Based on this evidence, it is clearly possible to increase the chance of surviving an attempt if an individual at risk has reduced access to lethal means in their moment of crisis. Additional evidence supports that the availability of method influences the choice of method. If a favored method becomes less available, individuals do not necessarily engage in means substitution. Reducing access to possible methods of suicide may be one of the most challenging tasks that a service provider faces with an individual at risk for suicide. The Counseling on Access to Lethal Means online training is offered free of charge by the Suicide Prevention Resource Center. The training is designed to increase knowledge of the association between access to lethal means and suicide, and the role of means restriction in prevention. The course is also intended to increase a provider's skills and confidence to assess and reduce a person's access to lethal means. Providers have historically focused on treating mental health problems such as depression, substance use, or anxiety, with the assumption that a person's suicidal thoughts and behaviors would cease once the other issues are resolved. Recent research strongly supports targeting and treating suicidal ideation and behavior specifically and directly in the least restrictive environment. These findings were independent of diagnosed mental health or substance use issues. Several evidence-based models of suicide treatment have emerged that effectively reduce suicidal thoughts and attempts. In the zero suicide model, all staff members who work with individuals at risk for suicide are trained to use these models, regardless of the setting. Newer models of care suggest that treatment and support of persons with suicide risk should be carried out in the least restrictive setting. Interventions should be designed, and providers should be sufficiently trained to work with the person in outpatient treatment with an array of support, and to avoid hospitalization if at all possible. The zero suicide model includes specific action steps to provide support to individuals in transition from one level of care to another who are at risk for suicide. The burden lies on providers rather than on individuals and their families to develop systems to ensure that individuals make and keep their appointments. Service providers must bridge the transition from inpatient care, emergency departments, or primary care to the outpatient behavioral health care. It is equally important to address suicide risk at every visit within the organization, from one provider to another, and between primary care and behavioral health care. In the National Survey of Drug Use and Health, of the adults who reported that they had attempted suicide in the past 12 months, 46% received no mental health treatment, even though 60% of those who attempted suicide had received medical attention for the suicide attempt, and 43% had stayed overnight in a hospital. 60% did not participate in any mental health visit, and 48% of those receiving mental health treatment received only prescription medication for a mental health disorder. This is insufficient care for someone with suicidal thoughts, let alone someone who has attempted suicide. There are several recommendations for appropriate follow-up and supportive contacts that can help with this transition period. First, providers need to use follow-up and supportive contacts for individuals who are transitioning between levels of care, and for individuals who are on a suicide care management plan, such as a safety plan. These contacts should be tracked and managed in the clinical record of the person. Second, persons at risk should be engaged in an individualized, culturally sensitive manner that takes into consideration their needs and preferences. Third, staff members need to be trained how to provide supportive, caring contacts and follow-up care using techniques such as motivational interviewing, safety planning, and lethal means assessment. With isolation as a strong risk factor for suicide, successful care transitions are especially important for the persons we serve. Timely supportive contact, such as calls, texts, letters, and visits, should be standard at critical times, including the transition between acute care visits, once the person begins treatment, and when the person is in a higher risk period, or when services are interrupted or an appointment is missed. Research has demonstrated that caring handwritten letters sent monthly to quarterly throughout the year for up to 5 years after inpatient hospitalization significantly reduced the number of suicide deaths among persons who received them compared to similar individuals who did not. The effect of the caring letters was significant even in the group who declined or refused treatment. This completes the video section of our lesson on suicide prevention using the Zero Suicide Model. In addition to viewing this video, the lesson includes reviewing all of the attachments that are included in the lesson media section of this lesson. Additionally, a copy of the PowerPoint slides for this lesson is included in the lesson media section. When you are comfortable with the information, you are required to complete the attached quiz with a passing score of at least 70% to successfully complete this lesson. Thank you for your time and attention. We hope that you're able to integrate this information into the services that you provide. Good luck with the quiz.